So let's do it the usual way that we do it. Age, gender, time frame. So what do you think of her age?
She's in
right?
a good area for immuno.
Yeah, right. So I think having looked at this case now, you always learn when you teach. I've now decided that when I'm doing 30s to 40s females, I'm going to add a second whole category. I'm going to go to autoimmune. I'm going to add a whole second category, which is going to be endocrine. You guys are going to be convinced when you get into practice that every 40-year-old woman has an endocrine problem. It's just like unbelievable. They have lumps and bumps and TSH is going out the wazoo, although I could argue that's Hashimoto's, so that's perfectly okay. Okay, gender is going to be female. So female repro, -1 athro, really common endocrine in females. What do you think about the time frame? When we say endocrine, what's time frame in endocrine? It depends, doesn't it? So every time we have to talk about how to think about the endocrine system, because it's actually multiple systems, isn't it? So we need a way of organizing that. So to be determined. What do we think about the chief complaint? Remember, a chief complaint is a place from which you can form a differential diagnosis. Did you guys form a chief complaint here? What do you think, Elias?
Her chief complaint is
in other words, not what it can be what she's complaining of, absolutely. But the way I use the term means I have a point from which I can form a differential, which is really practical. Where do you want to start with it?
I would focus probably on the weakness and the achy joints.
Okay. So when you say that, how tight is your differential?
It's pretty broad.
Really terrible, right? It's right in there with a little confused. It's like, oh, really? I have to do that, right? So yes, we can absolutely do that. Let's just start with that, okay? So let's start with, and this lumps categorically into this group. Fair enough?
Sure.
That's just good luck with that. So if the physical exam doesn't help you on a non-specific, whatever it is, they're all non-specific, what are you going to do? Right? Physical exam is non-contributory. Now what?
Well, if you have your history and your physical exam and you're still not getting anywhere, then that's when you introduce lab work, right?
Right. You go fishing, right? You're absolutely allowed to go fishing. And there's 3 tests you never have to justify because they're just so fundamental in our medicine that they're just perfectly okay. And they are the CBC, urinalysis, and the metabolic panel. Okay? Now, you guys have been on the wards. What is the difference between a basic metabolic panel and a comprehensive metabolic panel?
LFTs.
Are you checking liver?
It's just LFTs, right? So when you take a look at what we got here, this is going to be a comprehensive. So that's pretty easy. So now that I look at the lab, have I got a nice chief complaint?
Yeah.
Yeah, what do you want to go with? Because you got 2, right?
Yeah. Well, you have the hypercalcemia and the elevated alk phos.
And the elevated
What do you
livers.
want? What do you want to go with?
Hyperparathyroid?
You can do either, right? And what you hope is you hope they all meet at the same place. Otherwise, you've got 2 different things going on. So you always try to do a unifying differential if you can.
Yeah.
You get to pick where you start. You can do both, one, either.
So, I mean, when you look at this, I think you look at them together.
Okay.
Because alk phos comes from 2 places, right? We see it in the coming from like the bile duct, or we see it coming from bone, right?
Yeah, every cell has alk phos.
And if we look at,
and so there's a third that you're always going to do in here, just so you can check the box and move on, is going to be your placenta. Okay, so you should know if you're pregnant.
Yeah.
Okay, so but just remember, every cell has alk phos. These are just the big 2. But that's exactly right. Those are the big 2.
These are just the major ones, right?
Okay. So I guess we really don't want to start with alk phos, do we? Because that kind of...
you have to look at it with the calcium, right? I said both. So,
what we really want
with the calcium makes it...
With the alk phos elevated, though, in conjunction with elevated liver enzymes, wouldn't that also be more concerning?
Oh, absolutely. Okay. So nice. Let's just take a moment and talk about how testing works in the liver, okay? So when we say, how do you think about the liver? I always do this. There's my liver, but watch what I always do. I always do this. When I say liver, I always do that because we haven't done lung yet. When we get to lung, bronchial, alveolar. When I get to liver, hepatocyte, hepatobiliary, and bile tree. Okay? And when I say bile tree, I have a very specific picture in my mind, Richard. And like all things, you don't have to believe me, just try it. So when I say biliary tree, what picture do you have in your mind?
Well, I imagine the common bile duct.
See what I just did? Can you see what I just did there?
Yeah, I see it.
Right? You see how fast that was? You see how complete that was? So what is number one?
Here, 1 second.
Yeah, I'm sorry. If you can't see it, let me know.
No, I just have to move the window. So number one, I would say that's the left bile brain, like
out left hepatic duct.
Okay, left. Okay.
Okay, no, that's fine. I mean, again, practice, right? No one's ever asked you to do it this way. So this is your first organizational picture. So what the heck, right? Okay, what's number two?
The hepatic main.
Common hepatic duct, right? What's number three right there?
The common bile duct.
Cystic duct. That's coming to my gallbladder. That's a little unfair. Because what's this guy number here, number four?
That's the common bile duct.
Right, there's my common. And you see how hard words are compared to pictures? Okay, so then what's number five going to be?
That's a connection to the pancreas.
Right, so that's got to be my pancreatic. You see how I always put them in there because they connect. Okay, so the question you have to ask yourself is, why did I draw a little circle there?
Because that's going to be the sphincter of Oddi.
It's the what?
The sphincter of Oddi.
Yeah, it is, but why do I care?
Because that's going to be the connection to the duodenum. That's going to be where
why do I
pancreatic
care?
Enzymes. Because
why do I care?
Because it's a junction between the
pancreatic. You ready for this? You're going to like this, Richard. You ready for this universal principle? Every time that you have any structure that's a body that's a tube, you always want to know the narrowest spot. Because that's where every friggin' thing hangs up, right? So the three tubes, you just always keep in mind the three narrow spots because it's just so friggin' common in medicine. One's going to be the biliary tree. So when you say, why is the ampulla of Vater matter? It's because it's the narrowest spot, and it's the narrowest spot because of the sphincter of Oddi. So if I have a common duct stone, right, let's just I'll put a big fat common duct stone right there. Can you see it from the duodenum? Can you just look up through the sphincter and see it?
Probably not.
Absolutely you can. No kidding. It's hung up on the sphincter. So how easy is it to grab a sphere? If you just get that little tooth grabber, how easy is it to, it slips away, right? So how are you going to get that common duct stone out at endoscopy?
An ERCP, probably just like a pair of pincers on the instrument.
You just cut the sphincter. You just do a sphincterectomy. And all of a sudden the narrow spot becomes the bigger spot, blick, plunk, everybody's happy. So you can see just that little story. You'll never forget that anatomy, will you? You sort of go, got it, that's just a great story. You'll never have to think about it. You'll never have to learn it because in every tube you learn the narrow areas. Okay, let's do our other two tubes. Where's the narrowest spot of the small bowel?
Splenic flexure.
The splenic flexure is colon, and we're in small bowel.
The ileocolic junction.
Yes, and what's that called? There's a fatty little valve there.
Yeah, I know. I'm trying to remember the name.
So that's where you're going to find anybody swallow something, a golf ball or whatever. That's where you're going to find it, right? It's the ICV, ileocecal valve.
That's it.
Nice? Okay. So the next one's going to be, if you're going looking for a kidney stone, I guess you should know the 3 narrow spots of the ureter because that's where you're going to find them, right? Ureter.
Where it crosses the pelvis.
Nice. That's the least favorable one, but that's stuck in your brain. So that's really good. Crossing the pelvic rim. Excellent.
Coming into the bladder, vesicular junction.
Where it inserts into the bladder. Superb. UPJ.
UPJ.
UPJ, right? The uretero-pelvic junction. So right where that kidney narrows into the top. So when you say, where am I going to find my kidney stones? As with any tube, the 3 narrowings. Okay, and then the hepatocyte, right? Okay, so this is a very sophisticated group, so let's go all in on this. When I see ALT, why is ALT a fantastic marker of hepatocellular damage?
It's in
Because
the
it is. It's a
cytoplasm.
fantastic test.
Because it's in the cytoplasm of those cells, and so when you get breakdown, you get release.
Yeah, so let's try this principle, Alexander. If you have a protein that is unique to a cell, and I find that protein, do I know what's happened to that cell?
There's some damage.
Damn straight, right? If you've got a protein unique to a cell, you don't need to biopsy the cell because you can see it. So why do we think we talk about cardiac troponins?
It's unique.
Right? Why is amylase a pretty good test? Why is lipase better than amylase? Because
Specific.
only the pancreas has lipase. Yeah, lots of mucosas have amylase, including the parotid. So we're always talking about cell-specific, tissue-specific, and then just general like LDH. Every cell has glycolysis. So LDH is a really hard enzyme to work with. Good? So I guess if ALT, and I'm saying it's fantastic, it must be specific to the liver, right? So I guess I'm going to ask you, what does it do?
Oh, it's part of the the metabolism pathway that I totally forgot since year 1.
Yeah, right, because everything isn't equally important. Oh, this is looking good. Melissa's putting a bid in here.
Cori cycle?
Sadly, probably not quite right. It is gluconeogenesis, right? Because it's alanine. Remember, alanine sort of pegs out the conversion of gluconeogenesis from amino acids. So that's why it's alanine transferase. So you get a little tiny bit of gluconeogenesis from the kidney. Only a physiologist would care. So for a clinician, gluconeogenesis is a liver function, and there's my beautiful enzyme for it. So you know exactly what's happening in your liver by your ALT, right? Not true for ALK-Phos. ALK-Phos does not represent damage. ALK-Phos is induced. That's a totally different discussion now, right? Anything that stimulates your P450 can raise your ALK-Phos. So if I'm coming in and doing a little bit of the old glug-glug, can I raise my ALK-Phos just by drinking without any liver damage? There's no damage here, right? All your little epileptic kids, if they're on phenobarb, are their ALK-Phoses above and beyond their bone? And you can have a single little body, a single 1 to 2 centimeter mass against a biliary duct, and that will raise it. At some point in your career, you're going to go chasing an isolated elevated ALK-Phos, and when you image the liver, you're going to see a mass against a biliary duct. It could be a granuloma, it can be a tumor, it could be a cyst from an infection, but it's induced. So irritation can induce ALK-Phos. Everyone happy with that? Okay, so yeah, so ALK-Phos is good, but you notice I sort of shied away from that. I didn't like that we were going there because ALK-Phos, it turns out, multiple organs and complex because it's induced. So it's something you got to think about to use thoughtfully. But I do like hypercalcemia because watch this. Hypercalcemia is the first time we've shown you the power of algorithms. Anytime in medicine that you can organize by an algorithm, you absolutely want to do that. Because algorithms not only organize for you, they tell you what to do next. Now, sometimes they have great ways of doing it. Most of the time, we just organize them by incidence in your practice. So if you get in a practice with very different demographics, don't be shy in changing your algorithm so most common things come first. So if I'm going to do hypercalcemia in America, What am I absolutely going to look for first? What's absolutely the number one cause in America?
Parathyroidism.
Watch how I'm going to write this, Melissa. Primary hyperparathyroidism. And we're going to talk about why I said it that way. So what test do I do to look for primary hyperparathyroidism?
PTH.
PTH, right? Okay. If that is increased, now we have a specific group called primary hyperparathyroidism. We're going to talk about what you need to know in that. Now we come over here and it's normal. What would you do next?
PTHRP.
Oh, that's so clever. That's excellent. So if that is increased, what do I have?
Paraneoplastic.
It's paraneoplastic, so I got a cancer, right? Okay. If that is normal, what am I going to do next? Vitamin D. Because if that is increased, I'm going to have to put two diseases here. What are the two I got to put here?
Surreptitious vitamin D uptake.
Nice. Okay, so dietary, excellent.
Granulomatous disease.
Oh, that's so clever. And what's by far and away my best granuloma?
Sarcoidosis.
Absolutely. Okay, and that if that's normal, then we go to the list. So if I was in pharmacology, what would the pharm people put down as the two drugs that give me this?
Thiazides?
Nice.
Lithium.
Always, whenever you say kidney, you always say lithium. Okay. But if you were a pathologist, what would you always want to put down here? What's my disease? Myeloma. If you were an endocrinologist, you'd put hyperthyroidism. And then the rest are all going to be rare. So you can appreciate when you take a look at that list. In America, watch this. This guy and this guy are 90% of all the hypercalcemias in America. Wow. Well, that went fast, didn't it? Okay. When I say hyperparathyroidism, what is going to be the commonest cause?
Men?
Fam?
Men.
Okay, that's a perfectly nice thought, Alexander. I like it a lot. Only 10% of them are MEN1s. So most of them are going to be, 90% of these, therefore, are going to be sporadic. So when I say sporadic, what are my commonest causes? I need three.
Parathyroid adenoma.
Adenoma is brilliant. That's actually my commonest one. That's a very nice answer, and that's going to be about 2/3 of them. Hyperplasia. So that means all four of them. And then the rarest by far is going to be a parathyroid carcinoma. Okay, so why did I write primary hyperparathyroidism instead of the specific pathology? And the problem you're going to face is this. How common is it to find hypercalcemia when you're screwing around just getting chemistries? It's really common. So the question is going to be, if they don't have a family MEN, how are you going to find adenoma, hyperplasia, and carcinoma? And this is the sad truth. Physical exam isn't going to tell you because the adenomas sit behind the thyroid. They're about 1 centimeter. You can't feel them. It turns out imaging isn't reliable. So what are you going to do? You know what you have to do? You have to do 4-quadrant open surgery. Well, now all of a sudden we're doing a risk-benefit discussion, right? How dangerous is it for this woman to perk along at 11.4? The answer is not at all. So what you're going to find is, even though you know the odds are it's an adenoma, man, if she's asymptomatic, it just isn't worth the risk of surgery. So you're just going to live with it, which means you'll never really know the pathology. And so the way you remember this little story is, you notice I didn't give you a pathologic description. I gave you a clinical description. Primary hyperparathyroidism, I've got something in the parathyroid making it, I don't know, one of the big three. So every time you go look up hypercalcemia, you'll never see pathology. It always is primary hyperparathyroidism because you recognize in real life, most of the time you just aren't going to know. If you do go and do your surgery, which you're going to do if the patient has symptoms, well, that's a totally different discussion. Then you will know your pathology. So when you wrestle with those terms, that's why it's an awkward phrase, right? It's a clinical description, not a pathologic description. Okay, so now all of a sudden you recognize you can do 90% of your patients by age, gender, time frame. Because who's going to be primary hyperparathyroidism? Yeah, 30 or 40-year-old woman, right? And who's going to be my cancer patient? Yeah, over 65 and sick. So when you know that, most of your hypercalcemias go really fast. Okay? Okay. So what do we have to know when we talk about structure function here? Well, let's go and do calcium metabolism, shall we? This is the picture you got to have in your head because every friggin' question I write and that any writer I respect writes is they're always going to give you a table with up-down arrows. Always. Man, nothing compares to the up-downs because you can't memorize them. They test whether you know it. So for the rest of your life, you're going to get your stupid up-down arrows, so you might as well just learn this picture. So let's talk first about cellular functioning at the organ level, okay? So when I get a piece of bone, remember when we talk about bone, we always talk about long bones and axial bones. And in long bones, we always talk about cortex and medulla. So you always want to know what the person means when they're talking about it, because all the medulla does is provide a structure for hematopoiesis. So almost invariably, if you're talking to an orthopod or anyone else about bone, they're really talking about the long bone that gives you structural strength. The medulla just sits there as a place to hang up your hematopoiesis. So when we go from our tissue and we go, how do you see this? You're always going to start with the regulatory cell, which is going to be my osteoblast. Everybody regulates the osteoblast. So whenever I say osteoblast, you're going to put your PTH receptor there, and you're going to put your estrogen receptor there. Remember, it's a steroid, so it has response elements, not a membrane receptor. The osteoblast is going to regulate the precursor cell for the osteoclast, which comes out of the bone marrow, and that's going to form my osteoclast. Okay? And that is such a critical relationship that the rank ligand from the osteoblast goes to the rank receptor on the precursor to the osteoclast. That's so critical. There's a secondary protein to really finely regulate that. The body regulates calcium phosphorus to the finest level you can imagine. And so this is where we're going to find our secondary regulatory, which is our osteoprotogyrin. So there's even a whole superimposed layer of regulation to truly fine-tune that. Okay, so as we look at this picture then, we ask ourselves, okay, so how does the osteoclast resorb bone? Well, what is bone? What is bone? When I say bone, what do you think?
Calcium phosphate matrix.
Okay, so it's going to be what type of collagen?
3? No, 1.
All right, so we're going to review our calcium, our collagens. Clearly, we need to do that. Okay, and we're going to talk about calcium phosphorus hydroxyapatite crystals. So now you can appreciate I have to have two things in my osteoclast to resorb, don't I? I have to have a type 1 collagenase, and I've got to have a way of dissolving the crystals. So how do we dissolve calcium? We dissolve it with acid. That's true if you come into my lab and I'm doing bone for histology. It's true if you come into the body. So how does the body create acid? The stomach has a dedicated cell. How does the rest of the body generate acid?
Lactate? Or bicarb?
Right? Through bicarb. So what enzyme do I need?
Carbonic anhydrase.
Okay, so every time you think about acid, other than the stomach, you're going to build that little formula in, right? Because we're going to have diseases of manipulation of that. Okay, so let's just take a little moment for Melissa and let's go through how we have to have collagen for clinical practice. There are 7 or 8 collagens. Only the first 4 matter in practice. The rest are very complex stories and I've forgotten them. When I say type 1, what is the bioengineering principle of type 1? Equal strength. When you want cabling, you're building your bridge, man, I just want strength. You're going for type 1. So what is bone built for? Strength. What are you going to find there? For sure you're going to find type 1. Okay? If I went to the aorta, what do you think I'm going to find there? You know it's going to be lots of type 1. It's going to be more type 1 than the others because you just got to hold that pulse. Okay, when I say type 2, what's that for? Type 2 is unique. It has the ability to bind to carbohydrates. And the reason that matters is it means it can absorb a little water. And what that water does is it gives it just the right amount of stiffness. So it has this nice a little bit of compressibility, but not a lot. And that's perfect for cartilage. So you get a little protection of the joint surface, but you're not walking on squishy sponge. So it has that unique ability to bind to carbohydrates, hold a little water, and have just the right amount of compressibility. When I say type 3, that's how I do cells. This provides the cellular infrastructure. Cells just can't sit there like goo. They're wrapped in this very fine mesh. So in pathology, when we do silver stains, this is what we mean when we say reticulin. It's at the cellular level now. So if I said to you, bones type 1, what do you think the liver is? Right? It's all type 3. And what that means is when you get a hepatic laceration, how easy is it to sew? Everything just pulls through because it's all just very fine layers of type 3 collagen wrapping around cells. So in every organ, when you think about surgery of an organ or how it feels or how tough it is, you always in your mind say, what is the type 1 to type 3 ratio? That's really how you think of every organ for how tough it's going to be. And then when I say type 4, that's going to be my basement membrane. So when I say type 4, give me 3 diseases that I would say, oh yeah, these are classic type 4 diseases. If we were going to write a multiple choice on type 4s, what would we pick?
Goodpasture?
Question. Was that a statement or a disease?
A disease, Goodpastures.
Oh, Goodpastures. Sorry, I thought you said professor. Goodpastures, right? So that's our autoimmune disease. That's a beautiful disease. And that's always used as our model for type 2 hypersensitivities. It's a type 4 collagen, the alpha 3 component. Brilliant. Give me hereditary.
Allport?
Nice. And that is on every friggin' exam now for the past year. They've asked about that because that's our model hereditary disease, right? How do they present, Alex?
Glomerular damage.
And so who's going to walk in the door and you're going to get it wrong?
Hematuria?
Right. They're going to walk in with hematuria, right? It's going to be a boy because it's X-linked. It's going to be a young boy. And so what are you going to automatically assume it is?
Allport? Hereditary?
Oh, you're going to assume it's post-strep glomerulonephritis because that's about a gazillion times more common than the 88 cases that have ever been described in Alports. Because remember, the red cells are coming through that damaged basement membrane, aren't they? So you're going to have red cell casts. So you're going to see 8-year-old boy, hematuria, red cell casts. Why wouldn't you think that? So what are the 2 things you're going to check the box off to rule it out? Yeah, right.
History of strep, some sort of strep disease. Otitis.
We have hear, deafness, and visual. And then, of course, it's X-linked, so 3-generational family tree. Okay, so stop and put that in your brain, Alex. Here's my nice little boy walking in with sudden onset hematuria red cell casts. What is medicine is always right. What is most common? And then what can't I afford to miss right now? So that's one of those check the box. And oh, by the way, this is a classic fooler. See that? Okay. And then we have one more. Why do I think about it in cancer?
You have to break through the basement membrane.
Right, because remember, this is the border between carcinoma in situ versus invasive. So I've spent my whole life thinking about basement membranes, right? Because that's what you're always following, that carcinoma in situ, looking for a place where it went through. Why? How does that change treatment?
It's different staging. So you go from local resection to now systemic therapy.
So you're telling me if I had one tiny little 13 cells going through the basement membrane, that's it. It's the mega stompamycin surgery. That doesn't feel right.
No, but you would upgrade it from a local.
Okay, keep going. That's better.
You'd have to go check the lymph nodes and...
yeah, for sure that, but better still. Remember, if something's carcinoma in situ, you only have to destroy the epithelium. So all of a sudden, right? Whereas what you're saying is the second I say invasion, even microinvasion, it's a cancer surgery. You've got to do resection margins and discuss staging. But if I say carcinoma in situ, what's your therapy?
Kill the epithelium.
Yeah, just destroy it. You can burn it, freeze it, chemistry, I don't care, right? But you can just scrape it off. That's absolutely out once it's invasive, right? Okay, happy with that? Okay, so here's how we think about bone, right? Okay, so how are you going to remember the acid? Well, this is just a great story that a Brit forensic pathologist told me. We were going out to a crime scene once and we were talking shop as we always did. And he was saying this story about London. When Europe got the Great Plague, something like a third of the population died. It's inconceivable what that must have been like. They died so fast that classic scene from Monty Python, bring out your dead, that's literally true. And so they would take these wagon loads of dead people and they just threw them into mass pits, threw lime on them, and covered them over for the next layer. And what that means is when you're building in London now, you come across human remains all the time. So it's too much. It's a big difference, right? Because if it's a current bone, it's a crime scene and construction stops. But if it's a plague bone, it's 500 years old, keep going. Well, it turns out that the soil of London is mildly acidic. And so he said what all the pathologists would do is you give them a bone and they'd see if they could just push a pen through it. Because if they could push a pen through it, guess what it didn't have? It didn't have any crystals left. So then you knew it was a plague victim. So every time you think about how do you get that, how does the body mobilize calcium, you just think about all those plague victims sitting with their bones in that mildly acidic soil and it just acid dissolves it off. Okay? So once we have this picture, a couple of things we have to do. I want you to give me, what is the bone disease where you have defective carbonic anhydrase? What bone disease is that? And doesn't that name make perfect sense? Osteopetrosis. The bones are stone. So not only are the bones brittle and break, what other problem are they going to have? They can't remodel the medulla. And so what do they lose if you fill in the medulla?
Hepatopoiesis.
Yeah. So what do they always have?
Anemia.
Extramedullary. That's why it's extramedullary, because it's out of the medulla. So what does the body do with chronic extramedullary hematopoiesis? Where does it put it?
Spleen.
And
Lymph nodes.
liver. It reactivates the embryologic forms. So when you see these, they not only have brittle bones, they also have hepatosplenomegaly because they've lost their marrow. Okay, so if they've got defective osteoclasts, how could you cure the disease? How crazy is that? Because your osteoblastic cells are a modified macrophage and they come out of the bone marrow. So you can literally give these children bone marrow transplants and give them normal hematopoiesis. They have normal macrophages, which will make normal osteoclasts. So it's really one of those rare diseases that teaches really quite interesting lessons. The other thing we want to do is we want to use this as a chance to talk about the drugs. Because remember, I've told you you're going to be driven by two epidemiologies, aren't you? You're going to be driven by boomers and you're going to be driven by obesity. So when you say boomers, what's a classic disease of old age is going to be osteoporosis. So you need a way of thinking about your drugs for osteoporosis, and they fit perfectly on this, right? Pharm teaches you molecular. Okay, so what's my number one drug for osteoporosis?
Bisphosphonates.
Nice. And what is their target?
Osteoclasts.
Absolutely. And see how much easier that is? That's just way easier, isn't it? Okay, what's my number two? It's denosumab, right? And what does denosumab do?
Anti-rank.
Right? Just like osteoprotogyrin, it mimics osteoprotogyrin, doesn't it? Okay, what is the drug that's going to act as a osteoblast stimulator and mimics PTH? And you can remember it because there's my para from my parathyroid hormone. So there's going to be my parathyroid. And then the last one is, which is the one that's going to act like estrogen? So that's going to be my raloxifene. And remember, that's a SERM. Selective estrogen receptor modulator. Okay, so that's a really nice little diagram. You can see it gives you a nice way of thinking about things. It gives you a nice way of talking about drugs. And then the only other disease I'll add in here is to remember, this is how most, when we talk about metastatic cancer has two basic pathways, right? One is local production of cytokines that are like rank, and then the other one is PTHRP. So whenever you talk about bone and metastases, you're going to build those two pathways into it. So it's a really helpful way of thinking about lots of things, right? Everyone happy with that? Okay. So once we've built that in and we can see our drugs and we can add some diseases and talk about some basics, what we want to finish up on is the universal image of calcium, phosphorus, and PTH. So let's build this image. This is a mandatory image. Take your picture of it. Practice it all day till it's just how you think. And we're going to start with really, really highly regulated calcium. So the first thing is going to be a decrease in calcium. And the organ you're going to draw, of course, is going to be my thyroid, because there's going to be my 1, 2, 3, 4 parathyroids. How often are there 5? 15%. Wow. So the parathyroid might not migrate with the thyroid. What would happen if it migrated with the thymus? Yeah, ends up in the mediastinum. Okay, so you're going to build 4. 4 is normal. Most of the time it's going to be great. Doesn't have to be. Okay, when the calcium drops, right, we're going to affect the parathyroid gland, and it's going to secrete PTH. How does it know to do that?
It has calcium receptors.
Okay, and the specific name for it is a calcium sensing receptor. Might as well get it right. If you're going to learn it right. So that's our calcium sensing receptor. How long does it take for my calcium to respond? When I drop my calcium, how long before PTH goes up? Seconds, minutes, hours, days, weeks, months, years, decades.
Hours?
10 to 20 minutes. And you know why you need to know that? Because when you go in and do your surgery for parathyroid adenomas, you know how you know you got it? Because you do an intraoperative PTH. And if you got it, it drops. That's how tight this regulation is. So I spent the first half of my life doing frozen sections. It was really hard to do. It worked really badly. It was a terrible feeling. And I spent the second half of my life putting point of care PTH machines into ORs because they kicked me out because my frozens were not very good. Okay, so when we have PTH, what you're talking about now is you're talking about bone and kidney. And when we talk about bone, right, now we're doing osteoblast. And there's my PTH receptor. And remember, every time I stimulate that PTH receptor, I get an alk-phos. Alk-phos in bone is a measure of osteoblast stimulation by PTA. Is that reliable? Abso-friggin-lutely. Take that to the bank. That's a lock. Okay? So now you can see this is going to go from my osteoblast to my clast, and it's going to release calcium, and it's going to release phosphorus. Easy peasy, right? And you can build your whole cellular pathway with your osteoblast, osteoclast. Okay, so tell me what happens when I come over to the kidney. We're going to draw a nephron. You absolutely have to have the nephron in your mind to do this. So let's draw my nephron. And we're going to do three things on the nephron. The first thing here in my proximal convoluted tubule, I'm going to take a proximal convoluted tubule cell, and I'm going to have my sodium phosphorus channel. So, yep, got to know that. And then over here in my distal convoluted tubule, I'm going to build my PTH receptor. Okay, so this is my phosphorus regulation, and it has a bunch of things. We're not going to go into all the details, but one of the big things that PTH is going to do is it's going to dump phosphorus, and it's going to retain calcium. So calcium goes up, phosphorus is excreted. The second thing that it's going to do in the same proximal convoluted tubule cell is it's going to increase my 1-alpha hydroxylase. 1-alpha hydroxylase is going to make my vitamin D3 calcitriol. That's my active form of vitamin D. So that means I'm now going to build in my gut, and it's going to increase absorption of calcium and phosphorus. So every time we talk about calcium, phosphorus, and PTH, and you get your up-down tables, this is the way you've got to do them. So you can see then we've got all these conflicting forces. So if we say, what is the overall effect of PTH? I've got bone, I've got gut, and I've got kidney. So the effect of PTH is going to be for calcium, increase, increase, increase. For phosphorus, it's going to be increase, increase, decrease. And so the net is going to be increase calcium, decrease phosphorus. So you can see then you need 3 mental images to really handle anything that can come up in this problem. Okay, so I'm going to come through on our picture here, and I'm going to put in the diseases. Fair enough? So when I come in and I say, give me the disease in which I don't have parathyroid glands.
Hypoparathyroidism.
Okay, so I can have congenital, and I can have acquired. So acquired is after thyroid surgery, right? Anytime you have a bigger than 4 centimeter thyroid cancer, it'll be a total thyroidectomy. You'll see that, okay? But what's the congenital?
DeGeorge.
Nice. What does DeGeorge come out of?
What do you mean?
Well, what's the defect? Nice.
I
Okay,
just know
now
it's
this is
midline.
oh,
like,
this is going to be a
Third
great
arch?
day.
Third and fourth branchial arch.
Yes, yes, and that's absolutely right. This is brilliant, you guys. Absolutely, third and fourth, right? And when we say what comes out on the third and fourth, this is so good. Nicely done, everyone. So when I say third and fourth, right, this is going to be the parathyroids, the thymus, and the aortic arch. So what regulates it? Oh, this is a big day for you guys. This is worth the whole hour alone. You ready? This is my 22q11ds. This is the #1 commonest deletion syndrome in humans, and you're going to screen every pregnant woman for it. So if you haven't organized these into a single entity, nice day. This is a great day. So just write on a little piece of paper, put it in your front pocket, bring it out all week till 22q11ds is part of your brain. And now you can see it's got 3 ways of presenting, doesn't it? So it can present here as a hypocalcemic kid. It's going to be twitchy, irritable, might be more severe. It can present as my DeGeorge, recurrent infections over 2 years. Who walks in the door with the arch? Oh, this is so good. Who walks in the door with the arch? You ready? See if you can translate that. Commonest cause,
Tetralogy.
genital cyanosis.
Tetralogy below.
Tetralogy, right? Because the 2 great vessels come off the arch and you get this great vessel mismatch of a little skinny pulmonary and a really big overriding aorta. This is so common. This is 25% of the tetralogies. When you get a tetralogy, the first thing you're going to do is you're going to get a 22q11 screen. Well, that was good. I'm really glad we took the time for that. Okay. What is my hereditary defect of the calcium sensing receptor? This is advanced. I would expect this as a resident. No points lost if you can't do it.
Familial
Oh, you guys are so good. Yep. Familial.
hypercalcemia, hypocalciuria.
Yep. Hypocalciuric. Hypercalcemia. Really nice. That's really well done. Okay, that's brilliant. What else do we need to do here? Okay, come on over here. Obviously, this guy, we're going to put sarcoidosis here, aren't we? Okay, tell me about this guy. I want the PTH, the disease of the PTH receptor that's congenital. Yep. This is my pseudo hypoparathyroidism, isn't it? Okay. Who's this guy right here? When we talk about calcium metabolism and renal failure, you're going to start, this guy becomes abnormal in stage 2, but when you get to advanced stage 4, the PTH can't compensate anymore. So when you say, what do I see in renal failure? You see an increase in phosphorus, a decrease in calcium, and an increase in PTH. So you can compensate from stage 2 to stage 4 by 20 milliliters a minute. The EGFR is so severely compromised, you can flog it with all the PTH you want. It's not going to compensate for it. Okay? Okay, tell me what I would see here with celiac sprue.
Low on both.
Yeah, right, because I'm going to have fat I could have a vitamin D deficiency, and I could have a decreased absorption of calcium. So that's going to be a double hit there, right? Have I missed any? And then obviously over here with my class, there's going to be my osteopetrosis. You guys can add osteoporosis. That's going to be so common for you guys, you got to add it. That's a pretty good list, hey? So you can appreciate, you can do your drugs off the cellular picture, and you can do a huge number of your diseases off it. So obviously I can give myself an adenoma here for primary hyperparathyroidism. Missed any others? Pretty good. Okay. So let's finish up the day using our picture. So have the picture in front of you because you've just started to do it. And let's go through and see if we can finish these off. Okay. So remember when I do this, what I'm going to do, right? I'm going to have my PTH. I'm going to go over here to bone, to kidney, and to gut. That's how I always think of that, right? And then this is going to be vitamin D. Okay. What's number 1?
Primary.
Right?
Primary hyperparathyroidism.
So this is my primary hyperparathyroidism. This is where you always start. You always say, what does PTH do? The net of PTH is increased calcium, decreased phosphorus. And how does PTH work? On the osteoblast, right? And always upregulates what enzyme? Always.
Alk phos.
Right? So there's your alk phos right there. So this is the pattern you always start with. When you do this, it's because you can see the net effect of PTH. Okay? What's number 2? I haven't looked at these in a long time. I better pay attention here. Okay? I got an opinion.
Granulomatous.
Yeah, I like that a lot, right? Because these two look the same, don't they? Right? So I can go with an increase of 1 alpha hydroxylase, right? But what would give me the exact same look?
Hypoparathyroidism.
Hypoparathyroidism is going to be, what's the calcium?
No.
Yeah.
What is the defect in pseudo hypoparathyroidism?
The distal convoluted
Right,
tubule
it's a defect
receptor.
in the receptor. So if I can't resorb my calcium, I'm going to have hypocalcemia, right? Not hyper. This is
What
a
about
hyper.
just but just hypoparathyroidism, where you don't have any parathyroid?
So what's your calcium going to be if you don't have any PTH working on the PTH receptor,
That would be low, yeah.
right? So remember, always pay attention to whether you're in calcium high, calcium low. This is just going to be an increase in vitamin D3, right? Well, uh-oh, how are you going to tell those apart? Oh, man, this sucks, man. You got to give me vitamin D metabolism. Oh, man. Okay, so let's start off here with cholesterol. What converts it into cholecalciferol? That's going to be in,
Again.
okay? Then I'm going to go to my liver, and what's it going to convert it to?
25.
Right? So that's now going to be my liver. And then I'm going to go to my kidney and my 1 alpha hydroxylase, and that's going to give me my, that's why it's a 1. That's why it's 1, right? Because there's my 1 cholecalciferol, right? So can you see the difference of how you're going to test this? What is the major storage form of vitamin D? And when I say storage, this is the same way you take it in vitamins. So now can you see how I can differentiate vitamins, right? How am I going to be able to differentiate vitamins from sarcoid? Because when I test this, vitamin D, it's going to have a really high level of 25. But what am I going to have in sarcoid?
125.
Right. So this is going to be 125, and this is going to be 25. So if you have vitamin detoxicosis, remember the 1 alpha can only come out of the kidney, so it's got to have 1 alpha hydroxylase. So you can differentiate vitamin pills, which are 25, from sarcoid, which will create 125.
Can I ask a question?
Of course.
So with the granulomas, isn't that an increase in 25 because you have an increase in the macrophages there?
So one of the really important things to do in life is always throw your opinion out there and see if you have it right in your head. Right? So it turns out that macrophages have really high levels, who knew, of 1-alpha.
That's 1-alpha. Okay. Thank you.
So what that tells you is it's going to be a 125 dihydroxycholecalciferol. So what neoplasm could I get hypercalcemia in? Lymphoma. Because lymphoid macrophage cells have 1-alpha, and you get a big bulky disease, you can get enough of them. And when we say bulky means big in mass, like grapefruits, right? Mangoes, big tumor. You get enough enzyme, you see these systemic effects. Yeah, so what you've been missing is you've just never sat down and write out your vitamin D metabolism. And you've known 1-alpha forever, right? So if you just go, it's 125, you can kind of hang on to it for a while. Everyone happy with that? Okay. And then number 4. What the heck, right? Because what does this tell you? Right? That's a PTH pattern, right? Well, what the heck? And we know it's PTH. What the heck?
THRP.
Yeah. Right. And so that's classic. So remember, when you're looking at your patients, this one plus this one, that's 90% of all the cases you're going to see, right? And then you add in your vitamin D sarcoid, everything else is going to be really uncommon, drugs, myeloma, that kind of stuff. Everyone happy? Okay. So you know what I'm going to do? I'm going to leave you these guys, right? I'm going to leave you these guys. I'll just do this. I don't know if you've ever had the dimple sign explained to you, but just having someone walk through a dimple sign once really does help. I read about it for years. Don't think I ever really understood it until I actually had a picture. Someone showed me a picture of it. The dimple sign says this: when you make a fist, let me see if I can show you this. You miss this knuckle. You're missing the 4th knuckle. That's what a dimple sign is. And the reason for it is because if we draw in our metacarpals, they look like this. But this guy has a short metacarpal. So that when you go to make a fist, there's my metacarpal, there's my metacarpal, there's my metacarpal. Yeah, this guy, there's his metacarpal. So you've got a dimple. And everyone is, I promise you, medicine is fascinated by this. Anyone writing a question for sure will give, I would do it too. It's just something really cool about walking in and going, hey, you're missing your 4th knuckle, little short kid with a moon face. I know exactly who you are. Okay, so it represented far more than the disease, just because it's one of those quirky things that medicine likes. Okay, I will send you out, we're at our time now, I will send you out your PDF, and in it I'll put the answers for this, okay? So you can go draw the picture. Proof of picture is you can do the arrows. And then just keep drawing that picture until it's just part of how you see the world. Do the cells, do the picture, and if you're really feeling brave, do the vitamin D.